Hello everyone, I'm Fabrice André, professor of medical oncology at Institut Gustave Roussy in Vichy, France. Welcome to this program titled As the Expert, Understanding the Latest Advances in Breast Cancer. Joining me today are two US colleagues, Aditya Bardia, professor of medicine at UCLA and director of several UCLA-based research programs in Los Angeles. Hello, Aditya.
Hello, Fabrice.
And we have Erika Milton, director, breast cancer and gynecologic cancer research program, principal investigator at Sarah Cannon Cancer Institute, Nashville, United States. Hello, Erika.
Happy to join you guys.
In this session, many of the data we will cover were recently presented in Chicago during the ASCO conference, and each of us is going to lead a discussion on the following important topic. So first, we will have Aditya discussing about ADC in advanced breast cancer. How is the landscape evolving? Then I will discuss in the second time ADC in early breast cancer. And finally, Erika will present a small molecule for breast cancer treatment, what's new. And at the end, we will have time for discussion. So please don't forget to submit your question and we will have an open general discussion trying to answer your question or at least give our opinion. Without waiting, we are going to move to you, Aditya, to lead our first topic, antibody drug conjugate in advanced breast cancer.
Absolutely. Thanks so much, Fabrice. Pleasure to be here. So I'll review three things today over the next 8 to 10 minutes. First, talk about the latest on HER2-low and HER2-ultra-low advanced breast cancer. Then review TROP2-directed ADCs, and then finally drug combination of ADCs with IO. So let's first start with Destiny Breast 06. There were a number of important presentations at ASCO. This was probably one of the most important ones, was a special session at ASCO dedicated to Destiny Breast 06. This was a clinical trial that looked at patients with hormone receptor positive metastatic breast cancer. And it was different from Destiny Breast 04, which was presented a couple of years ago at ASCO. As a reminder, Destiny Breast 04 was predominantly for patients with hormone receptor positive, HER2-low metastatic breast cancer. About 10% of patients had hormone receptor negative, HER2-low metastatic breast cancer. And the trial required one prior line of chemotherapy, showed improvement in progression-free survival and overall survival as compared to standard of care chemotherapy, which was eribulin, gemcitabine, and other standard chemo options, and was pretty much a practice-changing study. Destiny Breast 06 was different from Destiny Breast 04 related to two things. First is this was earlier lines. It did not require any prior chemotherapy. So it was the chemo-naive setting in metastatic breast cancer. And so accordingly, the control arm was capecitabine or paclitaxel, nab-paclitaxel, something we would use in the first-line chemo setting for patients with hormone receptor positive metastatic breast cancer after they have received endocrine-based treatment. The second difference was that it included patients with HER2 ultra-low disease. So that is patients who have some expression of HER2, not high enough to be called 1+, but not zero either. So some expression, less than 10% of the cells expressing HER2, that's incomplete. So would be called HER2 0+, or in this trial, it was called HER2 ultra-low. The primary endpoint was progression-free survival and a number of key secondary endpoints, including overall survival. So what did it show? The clinical trial essentially showed that TDXT was superior to standard of care chemotherapy, including capecitabine, a significant improvement in progression-free survival, a median progression-free survival of over 12 months. It was about 13 months versus 8 months with standard chemotherapy. The overall survival results are not mature at this time, but it was good to see improvement in progression-free survival. And I would say besides CDK4/6 inhibitors, we've not seen a median progression-free survival of over 12 months in this setting. So it is a therapy that showed progression-free survival that's clinically meaningful. But whenever we talk about therapies, we have to talk about efficacy as well as safety. And in terms of safety in this clinical trial, TDXT had side effects we would expect from TDXT. So nausea being the most common side effect. Some patients have myelosuppression as well. Pneumonitis, a rare side effect with TDXT, but something that can be very serious, was seen in the trial as well. And there were 3 deaths as well related to TDXT or grade 5 events seen in this clinical trial with TDXT. So we had a nice discussion at ASCO. It was led by Ian Kropp, asking, where should TDXT be used? Should all patients get TDXT in the first line setting? How do we balance risk and benefits? And I wanted to open this up. Fabrice, what do you think? Based on Destiny Breast 06, a lot of attention on this study. You saw the data. How would you use TDXT after Destiny Breast 04 and now that we have 06 as well?
Well, I think Aditya, of course, we are going to discuss that at the end. Uh, I think data are quite convincing to use it in the first line. There is a general question on how should we test HER2? Should we continue testing HER2 for TDXD? I think the key question is going to be first versus second line, but keeping in mind what our colleagues in lung cancer are facing. We are losing some patients before the second line. So maybe we can have a general discussion on this topic first versus second line during the Q&A.
Absolutely, that'll be great. And as a final point about Destiny Breast 06, the clinical trial did show that the benefit in HER2 low and ultra low was pretty similar in terms of median PFS. So it does bring the question, as you were saying, about how to test for HER2 and how to measure 0 plus versus 1 plus and 2 plus. Okay. So moving on to TROP2 directed ADC, we saw a couple of results at ASCO. The first one was related to a new TROP2 ADC called SAC-TMT. So that's sacituzumab tirumotecan. Sacituzumab is the TROP2 antibody, similar to sacituzumab govitecan, but the payload is different. It's tirumotecan. It's a TOP1 inhibitor, but more potent than SN38. And we saw the results of the phase 3 OptiTROP Breast 01 study. It was predominantly done in China, trial design very similar to ASCENT, which led to the approval of sacituzumab govitecan. And the results were very similar to ASCENT as well. Sacituzumab tirumotecan was superior to standard chemotherapy for patients with metastatic triple-negative breast cancer who had received 2 or more prior lines of chemotherapy. Median progression-free survival, 6.5 months, hazard ratio 0.32, overall survival in favor of SAC-TMT, hazard ratio 0.53. So very similar results to ASCENT, and there are other ongoing registration phase 3 trials in the US and globally looking at SAC-TMT, which could lead to approval of this drug. Another TROP2 ADC that's further along in development is Dato-DXd. It has a different antibody and a payload as compared to sacituzumab govitecan and SAC-TMT. And the payload, deruxtecan, is similar to TDXT, and the linker is similar as well. There are a number of phase 3 trials ongoing with Dato-DXd. At ASCO, we saw the PRO results from Tropion Breast 01. As a reminder, this was a trial for patients with metastatic hormone receptor-positive breast cancer who had received at least 1 prior line of chemotherapy. So very similar to Destiny Breast 04, the difference being that this was for HER2 low as well as HER2 IHC 0. The trial met its primary endpoint. Dato-DXd was superior to standard chemotherapy in terms of improvement in progression-free survival. We saw these data at ESMO last year, hazard ratio 0.63, median PFS around 7 months with Dato-DXd versus about 5 months with standard chemotherapy. At ASCO, we saw the PRO data, and the study showed that the time to deterioration in global health status, quality of life, pain, physical functioning, all of that was delayed with Dato-DXd as compared to standard chemotherapy, which is not surprising. Often in this setting, good disease control is the best way to palliate. And so, with better disease control, with a higher objective response rate, the quality of life deterioration was delayed with Dato-DXd. And the team looked at other PROs as well, including clinician reported safety data. And in general, all of them were in favor of Dato-DXd. So the company has filed for approval related to Dato-DXd, and we await the results from the FDA. Before we move on, probably would ask Erika, what did you think of the Tropion Breast-1 PRO data and putting Dato-DXd when we have other ADCs as well?
Yeah, I think that's a fantastic question. Hopefully, we can chat a little bit more about this. I think your point about, the best way of palliating really is to control the disease. I think sometimes we underestimate that. So certainly, I think we've seen very encouraging results really from all of our ADCs. And it's interesting because we have kind of, two TROP2s that are kind of further along, only one that's currently approved. And so they do have a little bit of a different side effect profile. And so it may be that, individual patients prefer one over the other, but I think we can get into some of those details.
Yeah, oh, that's a great point. And the schedule is different as well. So Dato-DXd is given every 3 weeks, SAC-TMT every 2 weeks, and then sacituzumab govitecan day 1, day 8, every 21 days. Great. I'll wrap up with drug combinations with ADCs. At ASCO 2024, we saw the results of SASI-IO study. This was a study combining sacituzumab govitecan with pembro versus sacituzumab govitecan in patients with metastatic hormone receptor-positive, HER2-negative breast cancer. The team enrolled patients regardless of PD-L1 status, but then did look at results stratified by PD-L1 status. And overall, the study did not meet statistical significance in terms of improvement in progression-free survival. But if you look at PFS and OS stratified by PD-L1, you do see a signal that sacituzumab govitecan, or SG, in combination with pembro was superior to SG with a median PFS of 11 months versus 6.7 months in the PD-L1 positive subgroup defined as CPS score of 1 or more. But in the PD-L1 negative subgroup, there was no difference in terms of SG plus pembro versus SG alone. In terms of looking at safety, the safety profile was as we would expect with the combination. So with SG, the number one side effect is neutropenia. So that is what was seen, diarrhea, nausea, and alopecia as well. And then IR-related AEs with the SG plus pembro combo. These are data with sacituzumab govitecan plus IO. We've also seen data with Dato-DXd in combination with IO in the Begonia study. First-line metastatic TNBC, objective response rate of 70%, pretty high objective response rate, and median PFS, more than a year. So definitely rationale of combining these TROP2 ADCs with IO, and I'm eagerly awaiting the results as these drugs move into the first-line setting for patients with metastatic TNBC, but also early breast cancer where they might have the most benefit. And then related to HER2 positive disease, we saw Destiny Breast 07 presented by Fabrice. As a reminder, this was a module study where the team looked at TDXT monotherapy, TDXT durva, as well as TDXT pertuzumab for patients with HER2 positive advanced breast cancer. And this was in patients who had not received prior therapy for MBC. So the first line setting, currently we use THP, the Cleopatra regimen. In that setting, team looked at TDXT monotherapy and TDXT pertuzumab. Very impressive results. Confirmed objective response rate of 76% with TDXT monotherapy and 84% with TDXT pertuzumab. If we look at PFS rate at 12 months, it was 80% with TDXT monotherapy and close to 90% with TDXT plus pertuzumab. So this, these are very promising results, and based on this, we would expect that TDXT would be superior to THP, the current regimen we use in the first line setting. We are waiting the results of the phase 3 trial, but based on this, it does look like TDXT would beat THP in this setting, and it would be a positive study. It would change how we practice management of patients with HER2 positive metastatic breast cancer. In terms of safety, again, pneumonitis was the major AE seen. So overall, I was very excited about these results and looking forward to the phase 3 trial. But open it up to Fabrice. You presented these results. What were your reaction and what do you feel about TDXT in the first line setting?
Well, thank you, Aditya. That was a interesting study to run because it was in the first line setting, testing new investigational drug. So far, the follow-up is short, so we cannot really conclude on PFS, but it seems that, as you mentioned, that the TDXD alone or TDXD in combination with pertuzumab is really promising combination. And there is an ongoing phase 3 trial that will maybe confirm the utility and the efficacy of this new regimen.
That's great. And we'll continue the discussion in the Q&A section. So we'll hand it over to Fabrice.
Thank you, Aditya. Before I move to the presentation, don't forget to send your comment on the chat. It's a unique opportunity to have key experts online like Erika and Aditya. So now we go to the field of ADC for patients with early stage breast cancer. What are the latest development? So before we get to ASCO 2024 data, we should remind everyone the Catalin. That was TDM1 versus trastuzumab in patients with HER2 overexpressing early stage breast cancer with residual disease post neoadjuvant treatment. OS data were presented at San Antonio 2023 after 7 years, and there was a 5% benefit in favor of TDM1. So meaning that we already have the clinical trial showing that ADC improves outcome in patients with early stage HER2 overexpressing breast cancer, and that was the data from Catherine, as I just mentioned, testing TDM1. What are the current development in the field of HER2 targeted ADC in early stage breast cancer? And there are at least 3 drugs under development: ARX788, TDM1, as previously mentioned, but there are still trial ongoing, especially trial testing combination. And there are several large trials, 900 patients, 1,600 patients, testing trastuzumab deruxtecan in patients with HER2 overexpressing early stage breast cancer. Destiny Breast 05, Destiny Breast 11, testing TDXD in patients with residual disease or TDXD in the neoadjuvant setting. So that was for HER2 overexpressing breast cancer. Now we are going to move to 2 trials that were tested in the context of I-SPY 2. Remember, I-SPY 2.2 is a novel neoadjuvant trial for patients selected to present a MammaPrint high risk, stage 2 or 3 breast cancer, and this platform investigate new drugs and how to personalize treatment to maximize pathology complete response rate. Since 2010, 23 agent or combination have been evaluated in this family of trials, in this platform of trial that is absolutely fascinating. 2 arms of I-SPY 2.2 were presented at ASCO 2024, Dato-DXd monotherapy and neoadjuvant Dato-DXd plus durvalumab. Before we start, maybe just few words about response predictive subtype in order to better understand how I-SPY is interpreted. So the colleagues at iSpy classified breast tumors according to efficacy, sensitivity to therapy, especially cytotoxic agent. It means that now we have, according to iSpy, 3 subtypes: immune responsive, DNA DRD, and HER2. And all the results of the new drugs are interpreted in each of these groups, except HER2 when the cancer is obviously HER2 negative. So maybe we can go to the next slide, and this is the study overview. I'm not going to go in the detail of the overview, or we are going to skip the Q&A session. But then, just to say, there are 3 different parts. The first part, Dato-DXd plus or minus durvalumab. Then paclitaxel plus or minus carbo plus or minus PD-1 inhibitor, and then AC plus or minus PD-1 inhibitor. So what are the results of the 2 trials that were presented? First, the efficacy of block A, Dato-DXd monotherapy in the neoadjuvant setting. What are the results? The model pathology complete response rate were 0.27, 27% in immune positive subtype, and 0.29 in immune negative DRD positive subtype. And when we look at receptor subtype, patient with hormone receptor negative, HER2 negative, the model pathology complete response rate was 26%. Okay, so this is for Dato-DXd single agent. Then, for the combination between Dato-DXd plus durvalumab in the immune positive subtype, the model pathology complete response rate was 65%. And it means that Dato-DXd plus durvalumab met the graduation threshold in the immune positive subtype. Okay, so what kind of information can we get from these 2 neoadjuvant trials? Obviously, some pathology complete response were achieved. Interesting high model PCR rate for the combination Dato plus durvalumab. We will come back during the discussion on this topic about how could we move forward the ADC in the neoadjuvant setting. Again, if you have any question on this topic, please don't hesitate to send your comment on the chat. And now I will move to Erika for her section about small molecules.
Thanks so much. I'm going to move away from ADCs, although certainly it's one of the very hot topics in breast cancer right now. And we're going to talk about small molecules. We're going to talk about CDK after CDK, and then we're also going to talk about PI3-mTOR. So for our first topic about CDK, we know that we have alpelisib, capivasertib now in this second line setting. It's approved by both the FDA and the EMA. We also have elacestrant for patients that have ESR1 mutations after disease progression on first line endocrine therapy. But there's still been a remaining question of, is there benefit for CDK4/6 inhibitors after somebody has already progressed on a CDK4/6 inhibitor? We've had some smaller trials, PACE, MAINTAIN, for example, but we did see the results of post-MONARCH at ASCO this year. This was probably really our highest quality data here, and it essentially looked at patients that had hormone receptor-positive, HER2-negative advanced breast cancer. They had already progressed on an AI and CDK4/6, or in the adjuvant setting, had had disease recurrence on or after CDK4/6 with endocrine therapy, although that was a very small, very, very small subset of the study, and looked at fulvestrant alone, which historically has kind of been our second line endocrine therapy of choice, or fulvestrant with abemaciclib. And what we really saw was kind of two separate analyses. One was the primary analysis was by investigator, and then we also saw a blinded independent central review. In terms of investigator-assessed progression-free survival, we did see longer PFS when abemaciclib was added to fulvestrant, 6 months versus 5.3 months. This was statistically significant. I think in terms of magnitude of benefit, certainly was not overwhelming. But we also saw something interesting when we looked at the blinded independent central review. Overall, across the board, regardless of arm, these patients actually were progression-free for longer. And so this probably represents a bias in investigators maybe taking people off study for clinical progression or a variety of other factors before they've really had radiologic progression. But we saw 12.9 versus 5.6 months progression-free survival in favor of abemaciclib there. So certainly numbers, that I think we're a little bit more comfortable with the magnitude of benefit there. In terms of response rate, we did see the overall response rate about triple. So 7% with fulvestrant alone, about 17% when we added abemaciclib, and the blinded independent central review was very similar, 8% versus 23%. So that same kind of 3 times as many responses. And what we saw was when we looked at prior duration of CDK4/6 or presence or absence of visceral mets, really this was consistent. So kind of adding another option potentially in that second line setting to a spot that is already getting to be pretty complicated. One question is what do we know about safety? So certainly we anticipate seeing both neutropenia and diarrhea with the abemaciclib. And remember that abemaciclib probably is our friendliest CDK4/6 in terms of counts, but we still see about a quarter of patients having grade 3 or greater neutropenia. It was encouraging that we saw diarrhea grade 3 or greater at less than 5%. So I think we've gotten much better at managing this, counseling our patients how to manage this at home. And so that was certainly reassuring and really evidence that most patients were able to tolerate this based on the fact that we only saw 6% of discontinuations. So let me move on to talk about the PI3 AKT P10 pathway a bit, and then we'll turn it over to Fabrice for questions and comments, and we would love for you to place any of those in the chat for us. So I already briefly mentioned alpelisib and capivasertib. Capitello 291 was a phase 3 trial that really led to our capivasertib data. We also have older agents like everolimus, which is an mTOR inhibitor that can still be used. And then we saw some data around inavolisib. This is a new drug targeting the PI3 signaling axis, and it was presented at San Antonio in 2023, just the very end of last year. And this year at FASCO, we saw further efficacy, safety, and some patient-reported outcome data that was reported with just shy of a 2-year follow-up. So briefly, just to remind you some of the Inavo 120 unique aspects of this trial. Remember, it again was hormone receptor positive patients, and they all had a PI3 alteration. So no patients that were wild type in this assay. What was also unique to this trial that we haven't seen in the other trials is that this was first line. This was progression during or within 12 months of adjuvant endocrine therapy completion. So this really was a very high-risk population that was untreated in the metastatic setting, but relapsed while on their adjuvant endocrine therapy. And so when we get into the PFS, you'll understand why that's kind of important. And so patients either receive fulvestrant palbociclib, remember fulvestrant is our backbone because they progressed while on AI, or fulvestrant palbociclib with inavolisib, our PI3 kinase inhibitor. We did see it met its primary endpoint at San Antonio. PFS was 15 months versus 7.3 months with fulvestrant palbo alone. And you say, gosh, that's really a shorter PFS than we would have anticipated. Remember this ultra high risk population that progressed on their adjuvant AI. And so that's really what driving it. So we see about a doubling of PFS, which I think is pretty compelling. We also saw a little bit of data, kind of a proxy for PFS2, really looked like the time from randomization to the end or discontinuation of the next treatment was around 24 months for the triplet, and was only about 15 months if we received fulvestrant and palbociclib. So this was reassuring as well. And we also saw that time to chemotherapy was delayed for these patients. In terms of safety, I think that's always the big question when we're talking about agents in this class. We saw the anticipated side effects: hyperglycemia, diarrhea, rash, and stomatitis. There was very strict inclusion criteria around diabetes, having an A1C less than 6, for example. So certainly, a unique patient population that we really can think about for this. So I'm going to hand over to Fabrice, and hoping we have some discussion points around this data.
Thank you, Erika. Thank you, Aditya, for the very nice presentation and for starting some point of the discussion. So what I'm going to do, I'm going to ask some question. First set of questions will be related to clinical practice. I mean, today practice. And these questions are for both of you, of course. So the first question is, well, we have seen, we have multiple ADC now effective in the HER2 low segment. We have seen some retrospective analysis about using an ADC after another one. So how would you guide, and what are your comments about this sequencing of ADCs? I don't know who want to start. Maybe Aditya, you want to start?
Yeah, absolutely. No, it's a question we're already facing in clinic with both TDXT and SG that are approved. And I think if we need to understand mechanisms of resistance, if it's predominantly antibody based, then you can use TDXT and then SG because it's HER2 and TROP2 antibodies. But if it's payload mediated, they have very similar payloads. And the newer ADCs that are coming in as well, DARO-DXd or SAC-TMT, they have similar payloads also. So I think we need to understand resistance, and I would suspect in a subset of patients, it's payload mediated. We saw data at ACR that some patients can develop TOP1 mutations after these ADCs, which can then confer cross resistance. So as a field, I think we need to develop ADCs with other payloads. But for now, outside of any prospective data, I would rather use one ADC after next than consider, say, eribulin or navalbine. So that's what I'm using in clinical practice. But when I use the second ADC, given that a subset of patients might have cross resistance, I get scans sooner rather than later. I don't want this patient to wait for 3 or 4 months before getting scanned again. I do a quick scan just to ensure that they don't have disease progression.
Thank you. Do you agree, Erika, or do you have some?
I completely agree with Aditya. I mean, there's no doubt about it. We see a marked kind of fall off in progression-free survival for that second ADC, really regardless of what order you give them in. But part of it is we shouldn't be surprised about that. When we get to, say, third-line triple-negative breast cancer, we anticipate PFSs that are very short, right? Our sacituzumab data, how poorly the control arm with single-agent chemotherapy did, really shows us that. So, I do think I completely agree with Aditya. I think, the target is going to matter. I think payload's going to matter. I unfortunately worry that we could have those issues within an individual patient from lesion to lesion. But, until we have data to show me otherwise, I think that ADC2 is probably still going to beat chemo. And so I am using ADCs in sequence, most pertinent right now for HER2 and TROP2 targeting ADCs, although we certainly have new ADCs coming.
Thank you. So you asked me the question previously, Aditya, and I did not answer. And now I have the privilege of being the chair, so I'm going to ask you the question to you. So trastuzumab deruxtecan based on Destiny Breast 06. Here I ask your opinion, and of course, guideline committee will decide. But what is your feeling? So first line, second line, depending on the patient. For all, what would be your general recommendation on this question, first versus second line?
Yeah, absolutely. We always take a patient-centered approach. So I think it would be a patient-centered, patient-informed approach. On one hand, we've seen significant improvement in progression-free survival. As I was saying, median PFS more than 12 months, and we like to use our therapy, the best therapy possible, earlier rather than later, because there's always a subset of patients who don't get to the second line. So say I use capecitabine, and then after capecitabine, patient has significant hepatic disease or abnormal LFTs, and I'm not able to use TDXT after that. That would be concerning. So that's a general principle in MBC, to use the most effective therapy. But having said that, you have to individualize treatment. It's IV, it can cause pneumonitis. So patients who have more indolent disease or bone-only disease, I think it's a discussion with patient to get an IV therapy versus oral capecitabine.
And you, Erika, what are your
I
thoughts about this?
completely, I completely agree. I tend to be a clinical trial purist. I think the data is very compelling. We know that this is an extremely active agent. But, we also know that our hormone receptor positive patients, most of them are kind of in this for the long haul. And so, for example, we have capecitabine that's oral, and it doesn't cause hair loss. And some of those considerations are pretty important for our patient. And so I've heard very smart people actually sit on both sides of this debate of, well, am I really going to universally use this first line, or am I going to use it second line? And I think it is a little bit more of an individualized patient decision. I totally think that, it's clear that the data and PFS is longer, but it is a little bit more of a stepwise approach in hormone receptor positive disease, maybe even more so than triple negative.
Yeah, something we should not forget, and I mean this is a comment because I see it sometimes in patient second opinion, is this wave of innovation should not make disappear all the drugs that are effective. You know what I mean? So I think indeed, I think it's better to give the better drug first line, but at the second line, we should not forget capecitabine because it's an old drug. So we have to be careful, to be sure that all colleagues remember that some drugs that were old still have some role in the second line or even further. Let's go about the HER2 testing. Maybe Erika. So what do you think from your opinion? Well, what is the evolution and when should we test for HER2? How and at the end, are you going to take this into account?
Yeah, I may have a little bit of a pessimistic view on this. I think, for a little bit, we were kind of handcuffed from what we thought we knew about HER2, right? For sacituzumab govitecan, for patritumab deruxtecan, very early on, we realized that kind of measuring TROP2 really didn't matter. Measuring HER3 probably doesn't matter. But we were kind of stuck with this measuring because we understood HER2, right? And so we got the drug in HER2 positive. Then we got it in low, and we keep kind of peeling back layers of the onion now. Now we're down to this ultra low, which is essentially a subset of the zeros that have less than 10% staining. We actually have data from ASCO last year that if we biopsy a patient enough, 4 or 5 times, we're guaranteed to find a low. And so surely the answer really isn't Swiss cheesing a bunch of lesions and biopsying our patient 5 times to get a low to be able to use the drug. And I think that pathologists, IHC was never designed to test the difference between a actual null 0 and a 0 plus, and it's not very precise. And so I think we're moving towards, really probably giving most patients an option to see this drug, because I think there's a lot of tumor heterogeneity in terms of HER2. I'm intrigued to hear you guys' opinion on this as well.
I fully agree. HER2 IHC was never designed to identify low expressors. It was designed to identify high expressors. So you're asking the assay to do something it was not designed to do. And given what we've seen with other ADCs that have bystander effect, essentially TDXT works across HER2 spectrum. Even HER2 IHC 0 is not 0. There is some HER2 expression there. And if you're stuck with the label in terms of, say, 0 plus, I bet if we ask a pathologist, are you absolutely sure there's not even one cell that has some HER2 staining? It would be no, there might be some cells. So I think we would essentially use TDXT regardless of HER2 expression. But that's my personal opinion.
Thank you, Aditya. then I have a question for you, Erika. That is the question that is difficult to ask. So now we have this wave of ADC with first line highly effective drugs. We have the first line endocrine sensitive, endocrine therapy plus CDK4, and in between we have the second line, usually Faslodex plus targeted therapy. So how do you see this landscape evolving? Do you think that ADC are going to be prescribed more and more post CDK4, or do you think the opposite will happen with now inavolisib, capivasertib, etc., etc.?
That's a fantastic question. I think it's one of the biggest unmet needs right now is we don't have great tools in our arsenal to figure out who's still endocrine sensitive and who isn't, right? Because it's clear when looking at the emerald curve, et cetera, about 40 to 50%, depending on, what you're looking at, fall off at that first scan. I feel pretty strongly that to just take people straight to ADC is a mistake. I think from having oral SERDs and these targeted agents in my phase 1 unit for years, I have patients that have been on oral SERD for 2 and 3 years now. And interestingly, they're not all ESR1 mutation. So, although it's tempting because you kind of realize that subsequent endocrine therapies aren't going to help everyone, for those that it does help, and they may have years before they have to move to a more chemotherapy-like drug with ADCs. Until we have a better assay, I am universally kind of using another line of endocrine therapy until they prove to me that their tumor is really endocrine resistant. And then I move on to ADCs really as a chemotherapy substitute, not as an endocrine therapy substitute.
Thank you. Maybe we can spend next 2 minutes on neoadjuvant, development of ADC. So what we learned now is that when you use an ADC neoadjuvant, there is some pathology complete response. So what do you both think that which data is missing to optimally develop ADC in this setting? So maybe, I don't know, Aditya, if you want to start.
Yeah, absolutely. We've seen data with I-SPY, and then previously we saw data from Neostar as well with sacituzumab govitecan, that these TROP2 ADCs as single agent PCR about 30% or so, which is higher than single agent taxanes, but much lower than what we've seen with ACT or the Keynote 522 regimen. So the first thing would be to combine it with IO, which does improve ADC response. But then I think we need to build further, either by combining with chemo or other ADC-based combos. We need to get to a PCR rate of, I would say 70, 80% in order to make a difference. And ADC alone, even with IO, is not going to do it.
I completely agree with Aditya. I actually think that this is a really exciting opportunity in the field. We've gotten smarter with hormone receptor positive disease, with risk stratification assays. Who can we kind of spare chemotherapy for? And I think we're really at that point, honestly, for some HER2 positives as well as triple negative now, that, the Keynote regimen for chemos and immunotherapy, it's a lot of treatment. And we know that there are some patients in there that actually are going to have good outcomes, and being able to kind of select those patients and maybe give them less is really attractive. It's not going to be for everyone, but kind of to allow the patient's tumor to tell us, hey, I'm going to be a good responder, and after these 4 cycles of ADC, I'm going to melt away or not, I think is really excited and really patient focused as well.
Thank you, Aditya. Thank you, Erika. So we could still discuss many hours on this topic. I think it was a very nice session. Now I'm a little bit disturbed because I don't know if I have to say something very precise at the end. But what I wanted to say is thank you everyone for having joined this discussion. Thank you, Erika. Thank you, Aditya. I think it was very nice presentation and a very interesting discussion. Please scan the QR code to claim credit and review disclosure. Thanks again, everyone, and maybe see you next time in a conference or in another Medscape event.
Thank you.
Thank
Bye,
you.
everyone.